Welcome to Health Systems CIO's interview with UW Medicine CIO Eric Neal and Chief Clinical Informatics Officer Dr. Todd Burstain. I'm Anthony Guerra, founder and editor-in-chief. Eric and Todd, thanks for joining me.
Yeah, thanks.
Pleasure.
Thanks for having us.
All right, excited to have a nice, fun chat with you today. Why don't you start off, Eric? I'm going to start with you. Why don't you just give us a little overview of your organization and your role?
You bet. We are UW Medicine, and there's a UW Health. UW Health is University of Wisconsin, but we're the other UW, or University of Washington, out in Seattle, and we're an academic health system. We manage the trauma center, the level 1 trauma center in town, Harborview Medical Center. You may see pictures in Grey's Anatomy and the Space Needle and other things, and that's kind of all fashioned after Harborview. Incredibly proud of also UW Medical Center and their 2 locations, and our clinic network, and our partnership and affiliation with Fred Hutch Cancer Center. We're a big research organization, research, patient education, or education and patient care. Those are kind of the 3 pillars of our health system. And my role is Chief Information Officer. Proud to serve in this role. Got a strong team of about 700 folks working every day to achieve our mission, which is to improve the health of the public.
All right, excellent. Todd, a little bit about your role.
So I'm the Chief Clinical Information Officer, which means that I help the physicians as well as the nurses use technology to improve the care of the public. We're focused on what we call the quadruple aim, which is improving patient care, quality and safety, doing that at a lower cost, doing that with better patient engagement, and at the same time keeping our providers and nurses happy, healthy, and efficient. It is quite a task, and we're fortunate to have a great team to be able to leverage technology to achieve that aim.
All right, excellent, very good. So let's start off by with a little congratulations on achieving a HIMSS Stage 6 for the EMR adoption, that level, which is one of the more advanced levels. I think it just goes up to 7. So congratulations on that, and let's talk a little bit about that. Any of the sort of the higher level things that are required under Stage 6, we can go through some of them. I have a bit of a list, but when we talk about achieving that and getting that recognition, what are the 1 or 2 processes that come to mind in terms of these were the real tough ones, the sort of final ones to get us over that level, and these were challenging and we made it. So Eric, I'm gonna start with you.
Well, I'm gonna punt it over to Todd. And the first thing I'll say is create a strong team. Make sure you've got a strong team and tight partnership with operations. Our clinical partners, and we do all of this for them. So we're just here doing this work for them. In fact, we had a really great meeting with our executives on Monday talking about HIMSS Stage 7 already, and how HIMSS and us achieving those benchmarks, the different ways it contributes to the health of the organization, why it's important. But in terms of what we needed to do for 6, Todd, what would you say?
Yeah, so just to echo a little bit of what Eric was just saying, the goal of this is not just simply to get an award or an acknowledgement. It's actually improving the care that we deliver. And the reason that the metrics were chosen for these different levels is because they reflect organizations that are able to accomplish that, do provide better care for their patients.
Right.
And that the folks that work in those organizations are more satisfied using the electronic health record to take care of the patient. So a great study by KLAS, that's KLAS, from 2019 and 2020 showed both for physicians and nurses that the higher the HIMSS stage, the higher the satisfaction is for both nurses and providers in using the electronic health record. And we know when the nurses and providers are happier using it, they're able to focus on better care for the patients and be able to deliver that better care. As far as what it takes to get to stage 6, there are some basic metrics about what's called barcode med-administration. In other words, when I go to give, as a nurse, the patient the medication, I scan both the medication to make sure it's the correct medication, and I scan the patient to make sure it's the correct patient getting that medication. The goals are above 90% for stage 6, above 95% for stage 7. And we're currently right at 95 to 96% across our 3 institutions. And this does really depend upon a tremendous effort by our nursing colleagues to emphasize the importance of patient safety with this, and that we think we all know that we're doing things correct, but scanning is the way to prove that is in fact correct, and to catch those 1 in 1,000, 1 in 10,000 errors that can happen, and make sure that they're really at 0. So barcode administration is one area. The other area that we have always succeeded very well on at UW is called computerized physician order entry, or CPOE. This means that the doctors are directly interacting with the electronic health record to put in orders, as opposed to just telling the nurse to put the order in, which is called a verbal order. As you remember in childhood playing telephone, the message often gets scrambled especially as you go down the chain, right? And this is why verbal orders can be so dangerous. And we want to see 95% of our orders being placed directly by the physician. Not only is it eliminate that error in communication, but also the ability of the system to provide feedback, such as that medication needs to be adjusted because of a patient's kidney disease or liver disease, or is interacting with another medication, maybe is not even available because of a shortage. All that type of communication can be done directly with the physician when the physician is the one entering in the medication or the order in the system. So we're very fortunate. We've been able to have our physicians really buy into this, and we've been at 98, 99% CPOE since we went live on Epic over 3 or 4 years ago. So really pleased with that. The last step, really, besides some of these metrics, is to be able to present a case about how we've been able to use technology to improve the care of our patients. And we began a process a few years ago looking at sepsis and how we care for patients who are suffering from sepsis, who enter our emergency room or who develop sepsis while they're here in the hospital. For those who are familiar with that, sepsis is the #1 cause of death in the hospital in patients in the United States, and has been for a long time. So this is a really important condition to know about. And what we know from the studies on sepsis is if you treat it aggressively and fast with the right treatment, you lower mortality. So if you are able to detect the disease within a few hours, be able to give folks the right antibiotics and enough fluids to keep their blood pressure up, that is really critically significant. What we were able to do is use Epic Sepsis Predictive Model to identify patients in the emergency room and on our floors who are likely to become septic. And that triggers an alert so that the team is aware of this patient, and a code sepsis is called. At that point in time, they have an order set that shows them the correct volume of fluids and the correct antibiotics to use, the correct labs to draw, et cetera. And all of that then flows downstream for faster and more efficient care. The result of that implementation occurred basically over a year and a half ago, has been a 17% drop in mortality at University of Washington's hospitals. That may not sound like a lot, but there's a lot of patients that get septic, and a 17% drop means that 1 patient every 5 days is being saved that otherwise would have died from sepsis. So we're really excited about the results of this. And it, again, it shows a clear example about how technology can be used to improve the healthcare of the public.
That's great, Todd. Thank you very much for that. You mentioned this epic sepsis prediction model. Um, is that AI?
It is not AI, but it is machine learning,
Okay.
which is a form of artificial intelligence. It's not the generative AI like you think of Chat GPT and that type of stuff, but this is a predictive model that we took that model and trained that model for 6 months on UW data so that we were able to refine the model for the type of patients that we see here in Washington. And then we're able to release the model. And so the model is looking at all kinds of different data points, vital signs. It looks at white blood cell count and lactate levels and all kinds of things like that. And then determine a sepsis score for that patient. And if the patient is above the threshold score, which I think is 6 here at UW, then all the alerts start firing on that patient and everybody becomes aware that this is a patient who may be potentially septic.
So, it's interesting, right? So that's machine learning. That's machine learning, which I guess we could think of as like AI light is
Yeah,
machine learning, right? So like, okay, so that's pretty good, 17% for machine learning. Um, Eric, the industry, and I think with good reason, is going crazy, but I don't mean that in a negative way with AI or the term AI. Maybe half of that, when we're talking about that, it's really ML. It's really machine learning. People just using the catch-all term of AI. I don't know if it matters. Maybe it does. Chat GPT is AI, right? Generative AI, so that's AI. So that means I'm messing around with that. Um, Eric, what's the difference? What does this all mean? What's the point? Does it matter? Or do you need to be doing stuff with AI? If so, are you? And what is it?
Well, that's a huge question, and we might need an entire podcast for that. But let me just tell you in general, there is a lot of hype around AI. Of course, there's the Gartner hype curve around AI, and hopefully we've crested that hype curve and we're coming down the other side of it. But it will stabilize at some point where we really come up with use cases to best utilize these tools. The thing that we preach around here time and time again is don't do AI for the sake of AI. Do AI in pursuit of our mission. Use AI to help achieve our strategic goals that the health system already has. Use it as a tool, an accelerator, a companion. But again, don't get bought up in the hype and just develop strategies and infrastructure around AI just because it's exciting. We need to use it to do we need to make business processes more efficient. We need to take better care of patients. We need to improve our communication with patients. There's so many different ways we can use it. And we're on that journey. All of healthcare is on that journey. Some are at different levels than others. We want to make sure that if we roll something out, it's actually providing value to the health system, because we could pump a lot of money into AI solutions. And if we don't do it wisely, it's money down the drain. So we're taking a measured approach. One of the most exciting things we're doing is what other health systems are doing, and that is the use of ambient technology. So we've got a pilot underway with physicians, and we'll be looking at that ambient technology and seeing if that improves their experience. Does it improve the quality of the documentation? Todd can talk about some of the measures, but will it improve the quality of the documentation? Potentially even improve our coding if the documentation is better? Will it improve the experience with the patient if the patient's able to sit there and talk with their physician rather than the physician tapping away on a keyboard? Will that be a better experience for the patient as well? Will the providers be more efficient in their documentation and not have to do as much pajama time, or we call it pajama time, but time at home at night, finishing their day out and documenting after dinner, after they put the kids to bed or whatever. All of these are benefits that we think are coming with ambient, but ambient's just scratching the surface. I'm telling you, these tools are going to make us more efficient. They're going to help and supplement the work of our clinicians. They're going to benefit greatly from the busy work, the consolidation of data, the bringing the right data to the forefront for them, helping support the work they do. A lot of times I hear people scared that AI is going to replace them. I think AI is going to turbocharge them. It's really going to bring the data to their fingertips and let them make better, faster decisions and provide better care.
Yeah, just
Yeah, go
on,
ahead, Todd.
on that point, one of the things that has happened since we've gone to electronic health records is the explosion in the amount of data on any one patient. It is truly daunting. I remember the days back when, you would go, oh my God, when somebody would show up and their medical records would come in boxes, not in charts, right? And so, but now everybody's data is in boxes, essentially. It's just all electronically stored. And so that's a problem because you miss things. There's so much there that it's hard to see everything. And one of the real benefits of AI is to be able to take that data, organize it as a provider would like to see it, knowing what specialty that provider is in the context of the care that's being provided, and be able to show that information, surface it all so that nothing is missed. Nothing is missed from the data at our own institution. And with the health exchange, we get a ton of records, billions literally of pieces of information are shared every year between UW and other healthcare organizations. So being able to surface that data, and even now the ability to reach back to some of the older technologies and look at scanned faxes that we get and be able to bring that data in and analyze it electronically using AI to surface the data that's in some of the older technologies, all to provide a clear window for the provider as to what's going on with the patient in front of them.
Anthony, we're talking about it because it's top of mind for us right now. It's another pilot project that we have going right now, is leveraging technology to do exactly what Todd just described.
Well, you mentioned the word pilot, and I want to ask you something that just came into my head that I've seen a few articles about recently. Something they're calling pilot fatigue. Have you seen this, Eric? So
Yeah,
obviously, we can imagine what that means. Is that a real thing for health systems? You want to try? It's almost like going to a buffet, and you want to try a little bit of everything. But every pilot that comes in is a not a burden, but there's a cost on the staff, on everybody who's going to be involved, on time and effort. So your thoughts, both of you can
yeah,
feel free to weigh in on that.
yeah. First of all, because of that very issue, we've been doing some work on defining what a pilot is. Because if we're implementing something, a lot of times we would call it a pilot when it's really just the first phase of the implementation. And if
Okay.
it's phase one, stop calling it a pilot.
Uh-huh.
Pilot is really where we're bringing in technology and we're evaluating it in real world to see if it's a solution we want to pursue or not. But let's be honest, if we decided we're moving forward with it, stop calling it a pilot. So that's one thing. Now you might say, well, we're going to move forward with it, but we haven't decided in what form or fashion, and we're going to figure that out in the pilot. That's valid as well. But you're
Hmm.
absolutely right. The amount of overhead required to execute a pilot successfully and generate and track metrics and generate those KPIs and digest it into a form that then can present it to executives. Is there an ROI here? Did it have an impact on the care of the patient and the experience of the providers? That's a ton of work and we don't have money to waste on investments that have little chance of paying off in terms of what I just said, financial, patient care, or the provider experience. So we've got to pick and choose our pilots carefully. But I'm feeling it as well, Anthony. I think others in the industry are, that um, we can't just be throwing these pilots around. But the AI is so exciting, Anthony. Everybody's hyped up about AI. Everybody's got all these great ideas. And so governance is really important. What kind of governance do you have for these AI projects? What kind of group is sifting through the wheat and determining which things should move forward and which things should not? A lot of times you'll have new solutions that come forward, and if you wait just a bit, maybe one of the foundational systems you already do business with, they're going to have a similar solution. They're just not there yet. So anyway, governance is really important right now when it comes to all these AI solutions coming out of the woodwork.
Yeah.
Well, let's talk about that. Todd, go ahead. You had something.
I was
Go
just
ahead.
going to add, it's not just the cost, right? Because if you're piloting one thing, then it delays your ability to look at a different solution as well. And frankly, most organizations don't have the ability to try out 5 or 6 different things at the same time. In order to really be efficient in that, as Eric was mentioning, governance is really key. And so just as an example with our ambient AI solution, we spent about 4 months really reviewing the industry, doing a full request for proposal, seeing what's out there, talking to folks, and really being very careful about how we select an individual solution to pilot. And I think that's really important work that folks should be doing.
All right, excellent. Let's talk a little bit more about governance. Absolutely, it's make or break, right? If you have a good governance approach, good process with good committees and the right people and the right flow and the right structure, it's going to save you a lot. If it's not good, it probably everything's going to be a nightmare. What does good governance look like? And I'd like to hear from both of you on that.
Well, I'll give you my opinion. I hate the word governance because it's got a negative connotation to it, right? No one wants to be governed. You don't wake up in the morning wanting to be governed or have somebody tell you what to do. And so the word itself, we have to get past the word, and we try to use the word partnership. And I like to say governance is a framework by which we partner with our clinical side of the house and our business champions. And of course, we're here to serve them. So if governance is a framework that makes us partner better and efficiently, then bring on more governance. At UW Medicine, we put a technology governance framework in place in the past couple of years, and it's a 3-tiered structure, with the top tier being the top executives from across the enterprise, co-chaired by our chief medical officer and our chief operating officer. IT takes a back seat. We're there to help facilitate and bring ideas forward, but the decisions on what technologies we deploy and how we spend the healthcare system's limited resources should really be up to the hospital leaders and the health system leaders. And so that's the way our tier 1 works. Our tier 2 committees, we have 10 of them, and Todd chairs the Clinical Applications Committee alongside, who's your co-chair?
Annalise.
Annalise Schleier, our Chief Medical Officer. So Annalise takes the number 1 seat. Todd, as the IT person, takes the number 2 seat. And then we have representatives that can represent clinical areas across the hospitals on which applications we use. But then we take Todd's, for example, and tier 3 underneath him, radiology needs a group. Radiation oncology needs their own group, on and on and on. Those are the tier 3 councils where they get really specialized. So a council can chew on a particular topic that's relevant to them, and they can decide what's important for IT to do for them. And they can bring that to the tier 2, and the tier 2 decides which of those to move forward. And finally, it goes into a plan, a long-range financial plan, a budget, where the rubber really hits the road, and gets approved by the tier 1. So to us, the most important thing is that there's a governance structure to take things to get people on the same page, and for that group, representatives of the organization to prioritize the work for us to then go execute on. Of course, all along the way, it's a partnership, right? I mean, we're informing them on, okay, what's the problem? Okay, here's some potential solutions. The governance committee, they chew on, okay, let's go with option number 2. Okay, then we partner with them to go execute on, is it a big project? Is it something we can go do with a ticket? There's this back and forth. So I think it's really a healthy way to do things. But governance is never a one and done thing. It's constantly evolving. It's got to shift with the business and the priorities of the business year by year. And it really needs to not just be, it's got to be forward looking.
Hmm.
Where are we going to be in this upcoming budget cycle? Where are we going to be in 3 years? What foundational things do we have to do now? For example, AI, just say, AI. Are there AI platforms we need to be implementing right now? Because we've got use cases coming that we're going to need a platform like this to help us execute on.
Todd, any thoughts on governance?
Yeah, I just to echo, all of our governance councils and committees are chaired by a dyad between an IT person and an operational person, whether that's business or clinical. And that partnership is really key. And what it allows for is really keeping in line with some guiding principles that we put forth in IT. So we had 8 guiding principles, and I'm not going to give you all of them, but some of them just to really highlight. One is systemness, and
Yeah.
we have 3 different facilities plus our primary care, and they each have a different bent to how they the population that they take care of. Harborview is a level 1 trauma center for the Alaska, Washington, Wyoming, Idaho, and Montana areas. It serves all of them.
Wow.
And it's a big area.
Yeah.
And then you have Montlake, which is a huge quaternary referral center and transplant center. And then we have Northwest, which is started out much more akin to a community hospital. And then we have all of our primary care clinics. And you can see the flavor of all those is very different. So if we don't have systemness, they're all on the same electronic health record. And so trying to be able to maintain that and push it forward and do all the new things really requires everybody to be on the same page. So the governance groups allows for us to achieve that systemness. And then the other thing that's really important is integration. So we are a firm believer that integration trumps interfacing. So a lot of folks will design their technology platform by going to find the best thing that's out there in every little area and then try and figure out how to tie all the pieces together with interfaces. That is a mistake. The ability to maintain those interfaces and have meaningful communication between the systems becomes factorially more difficult with time, for those who are familiar with statistics. So we believe in integration, which means it may not be the best, but if it's part of our innate system, part of our main electronic healthcare system, that is the solution we're going to go for, because the systems are all integrated together. And so what's going on in cardiology can talk to what's going on in surgery, can talk to what's going on in registration, can know what's going on in the pharmacy, and they're all on the same system and working together. So, and again, you don't get the ability to have integration over interfacing without governance.
But I just have to say, Anthony, the more systems you have, the more risk you have. The more systems you have to keep secure and protect the data. And if you can have as few platforms as possible and leverage those platforms to meet people's needs, that's highly preferred.
Yeah, absolutely. Listen, been talking about this particular niche of this topic with a lot of people recently. This this balance, this struggle, between staying in suite with your enterprise vendor and using the applications that they offer. And the other side of that coin we see is a push for innovation. And you'll see the innovation folks and a lot of the operational folks, and they want to use the tool that they have come across that they deem to be the best. And maybe they're right. Maybe, but as Todd talked about the issues of interfacing, it is, and as you were talking, I'm like, what a shame. What a shame that this is the situation. I understand this is the situation, but it is a shame because it does hinder our ability to use that cool one-off tool that somebody built. Now, let's say the cybersecurity implications of that tool are taken care of, and that's off the table. If we could plug it in the way we can plug in any appliance into a wall and they all work, unless you go to Europe or whatever else, but at least in this country, you can plug everything into a wall. wouldn't that be just wonderful? But we messed it up maybe with meaningful use. We got everybody on systems, but we forgot that part of it. And here we are. But and I get it. I'm not arguing the point of wanting to stay in suite, but it does seem a little bit like it's a little bit of a shame, or at least that shouldn't be the ideal end all state for all time. Eric, I love your thoughts.
Yeah, you're totally right. I blame Sony. They came out with those beta tapes instead of the VHS, and that started the whole thing. They wouldn't the tapes wouldn't work, and yeah. Yeah, getting the systems to all talk to each other. I just reminded we were just in a meeting last hour and talking about now. Wait a minute, all these interfaces you're talking about for this one-off solution, it's not a one and done. Every time we upgrade something that touches it, we could potentially break the. This is a lifelong commit. It's not dating. You get married when you build those new interfaces. So, yeah, the more standardization we can do, the better. But at the same time, we started this call telling you about ambient. We started telling you about a solution that'll distill information and bring it to provider AI empowered stuff. They are one-off companies. They're not part of our native EHR. They are big, innovative leaps that we are making. And, this is new. This AI is new space. For a lot of things, you can look at a company's track record and say, oh, this is a public company that's been around for 50 years and they have a proven track record. Some of this AI is brand new. All these companies are brand new. It's like there's more risk here for an organization. Who are we going to hitch our wagon to? There's the different kind of evaluation that has to happen with these newer vendors than we did with the old ones, because one can gobble up another, or a finance group comes in and gobbles up somebody and then jacks up your rates, and it's a treacherous landscape right now. I believe we've done a nice, thorough process using our governance, providing internal controls over that with our governance to ensure that we're making the smart decisions for the healthcare system, and we don't lock ourselves into something that we later regret.
Yeah.
So you're willing to go outside a suite when you have to. You just would rather avoid it. And I think that's probably the prevalent opinion out there among CIOs. We want to stay in suite where we can, and then people put different metrics on it in terms of, okay, user whoever, you want this application you found. Okay. Well, there's something comparable in suite that our enterprise vendor offers. If this in suite application does 80% of what you're looking to do over there, how about we stay in suite? So I've heard all these, people put kind of numbers on it sometimes. But it's interesting. Todd, your thoughts on this idea, this tension between innovation, and again, you're willing to go outside a suite, but you don't want to if you don't have to. How do you deal with that tension on the clinical side? Because you're getting requests from your users all the time.
No, it's definitely a challenge. I will say that from a technology standpoint, we're making improvements. We are a heck of a lot better now than we were 10 years ago. So the ability to have smart on fire API interfaces, the ability to have deep API interfaces with our EHR that is opening up and realizing that even though they're big, they can't be the be all end all of everything. And they are going to have to talk to other systems and talk deeply. So the technology behind the interface is improving dramatically, which definitely helps. But you still run into problems when you have two different systems. And a lot of that has to do with ontology and mapping, and what do you call something, right? Whether that's, what do you call a lab, a specific type of lab? Is it different in one system than the other? What do you call a disease in one system versus the other? A medication. So all those little nuances, they end up causing clinical uncertainty.
Mm.
The clinical uncertainty is where you started to get into safety issues, right? So it is a challenge that you have to balance the ability for these systems to talk to each other through interfaces that you can test and make sure that they're not going to create patient error issues. And at the same time, going to allow the systems to use these more innovative tools. So one great example of this is, you get a lab result from LabCorp. Well, that's done on different machines. It's done on different, normal ranges and everything else. And now you're bringing it into your system and comparing it to the same type of lab done on your machines with different reference ranges and everything else, right? Well, is that okay? Is that not okay? Each one of those needs to be looked at and assessed. And so it creates a very challenging clinical problem to try and bring everything together like this.
Anthony, I want to go back though. There is a place to find harmony. You mentioned the tension
Yeah.
between innovation and existing platforms and other things. But every now and then, the clouds part and the sun shines, and there is harmony. And harmony for a CIO is when a clinical leader or business leader comes to them with a vision, and we discuss the vision of what they're trying to do. And then we agree to some strategies to achieve that vision they have. And then we talk about technologies that might be used to execute the strategy to achieve the vision. That is a beautiful conversation. When they come to us with a solution that they saw at a show or a great salesperson talked them into something, then we have to re-engineer the conversation and go back to vision, strategy, and then work on the solution. And that can sometimes be hard to do depending on how good that salesperson was. So what we try to do is engage our leaders proactively on that vision and strategy conversation, so we don't reach friction points where somebody wants this really cool, shiny object, but it might not make sense for us.
Let me ask you something based on that, Eric. It also does work and should work in terms of the CIO role, where you are engaged enough and involved enough and listening enough to the operational folks in their meetings, listening to their problems, that you can proactively suggest solutions. Like, they didn't even think like technology could solve their problem. They're just talking about a problem. And you're like, oh, wait a minute. I know there's this thing that's going on out there, or I read about another health system that's doing it. So it's not simply just waiting for them to bring you issues. It's actively listening, right? Does that make
Yeah,
sense?
and watching
Yeah.
how they're using the system. I'm gonna point to Todd right here because
There's
he's got
great
this
examples.
informatics team of nurses and physicians in IT and our informatics group. That's really part of their mission, is to do that proactively so we don't end up with what you were describing there. So Todd should really answer this.
Yeah, I'm going to give you a great example of this, and this is something we now call IUPA, but it's instant order practice alerts. And so you think about a problem where you want to get a behavior to happen, right? So our initial step with this was we had certain patients that we wanted to make sure that all the patients that met this criteria had a referral to a psychiatry consult.
Mm-hmm.
And it wasn't happening. And so we said, okay, the typical standard response is, let's put an alert in to remind the folks that they didn't do that, right? And providers and nurses hate these alerts, right? Because in a sense, it's the computer saying, you screwed up. You didn't do what you should do, right? And there's just something about your personality that you don't like it when the computer tells you you're doing something wrong, especially when it's your business and you think you're the expert in it, right? But we all know that we make mistakes and we slip up and we get distracted. And so in order to achieve the best results, you need to do these types of alerts. But now we're reaching technology to solutions that they hadn't thought about,
Mm-hmm.
which is we now have the ability to actually execute the order without even getting the person involved in it. So if we can say 100% of the time that this condition occurs or this situation occurs, that this is the output that we want this test ordered, or we want this referral made, or this, that, and the other, then just let the computer do it and take care of it, and don't even involve the nurse or provider, right? And so we put these in place already for lots of different things, right?
A nurse or a doc probably wouldn't have thought of that as the solution because they're used to the old way of it happening. So it is a good example of, how do we proactively help them with solutions that maybe they hadn't even thought of.
Brilliant. Gentlemen, we're almost out of time, but I think I have an idea for a final question, a way to wrap this up. Um, let's do it this way. Todd, I want to start with you as a clinical physician and a clinical informatics person. If you had a message for a CIO at another health system, certainly not Eric, that was not finding success in their role at a hospital, what would your best advice be to that person in terms of working with the clinical folks? What's the key there?
Um, I think you need to first and foremost have a shared vision. Um, IT needs to have the same vision that the hospital organization leadership needs to have, right? So you need to both be very clear on what that vision is. And then the second thing is you have to have open and clear communication between the groups. So that if you're veering off from that vision, or not executing on that vision, or having difficulty resourcing that vision, whatever it is, that there's communication that occurs between the two groups to be able to get you back on track.
Perfect. And Eric, let's do it the other way around. What would your advice be to CMIOs out there who want to work more effectively with their IT partner? Maybe it's not going great.
Yeah, I would say, look inward first. Are you aligned with the mission? Are you seeing the big picture? The CIO might be making decisions that may not feel right, but their CIO might have other political or budgetary or other things going on that come into play. So do you have a great relationship with your CIO? Can you talk about these things, maybe behind closed doors, about
Mm.
all the dynamics that come into play in the decision making? Because once you have the same information, 99% of the time you're going to reach the same conclusion. It's just getting to that spot. So that would definitely be a priority of mine. And then, I was thinking, you started this call, Anthony. You want to talk to us about HIMSS Stage 6, right? And so, yeah, we did. We went after stage,
Look.
we achieved stage 6, and now we're going to go after 7. But why now? And honestly, we implemented Epic 3 years ago. It took us a year to stabilize. That's tough, right? And we implemented Epic in the middle of COVID. You talk about tough. We had to do it virtually. And then it took us 2 years of optimization to get this system dialed in, to then get to a maturity where we could even go for a HIMSS Stage 6 or most wired recognition and other things that we've just done in this last year. But now what's the next phase? Thinking towards the future, I'll tell you the next phase is all about change management and adoption of these tools we built. And if I don't have a great partnership with my CMI, if we don't have a great partnership, adoption and change management is impossible. So we built the Ferrari. Now we're teaching the users how to drive this, and you can't do it without this kind of a partnership.
No. But Todd, you got to admit, 20 years ago, you wouldn't be hanging out with the IT guy. Things have changed.
Yeah, for sure.
Great stuff. Gentlemen, I've truly enjoyed this. It was a wonderful chat. Thank you so much, and look forward to chatting again down the road. You guys have a great day. Thank
Thanks
you.
so much, Anthony. It was fun. Thank you.